Okay. Well, thank you so much, and greetings to everyone. Today, we're just delighted to highlight some recent efforts from the NIH Adherence Network and OBSSR to advance the science and practice of health behavior maintenance. My name is Mike Starrett. I'm a senior behavioral scientist. I work at the NIMH Division of AIDS Research. And today, I'm joined by my colleagues Maureen Monahan Center from NIDDK, and also Sydney O'Connor and Deborah Young-Hyman from OBSSR. And in our presentation this morning, you'll hear from each of us in turn, and this is a real reflection of how this project has been a genuine team effort. And being a part of it has really been one of the best and most rewarding professional experiences in my personal career. So our talk today is in 3 parts. And first, what I'll do is give you a little background on the NIH Adherence Network, which is an internal scientific interest group here at NIH that leads adherence research. Then second, Maureen is going to discuss the concepts of adherence and health behavior maintenance, which are important challenges for us to tackle in the behavioral and social sciences. And then finally, Sydney and Deborah will share how the NIH Adherence Network and OBSSR have recently partnered on an ongoing series of workshops and other activities that are designed to further advance our understanding and support for the long-term maintenance of health behaviors. And as we drive through this talk, we'll also be sharing some links in the chat to some new online resources and to some funding opportunities. Let's see. There we go. Okay. All right, so let me start at the start, which is with the Adherence Network. So the NIH Adherence Research Network is an internal scientific interest group here at NIH. And we've adopted a mission to provide leadership, vision, and support to NIH adherence research. And we aim to accomplish that goal by evaluating and disseminating scientific information and funding opportunities for adherence research at NIH. Our group is comprised of both extramural and intramural NIH staff members who currently represent 18 different NIH institutes, centers, and offices, each of which is illustrated here. And to me, the exceptionally large number of NIH groups that participate in the network really signifies how adherence to medicines and other recommended health regimens is one area of the behavioral and social sciences that has truly broad and cross-cutting interest across NIH. This is our current leadership and members. And for a group this big, please receive my apologies if we somehow left anyone off in error. But it's my great pleasure and honor to serve as the co-chair for the group, alongside the terrific Maureen Monahan Center. And we send a special shout out to Janet Demore at NCI, who is a great colleague who recently stepped down from a long-standing co-chair role in the network to take on new responsibilities. The NIH Adherence Network has always had very close ties with OBSSR, and we're honored to have Deborah Young-Hyman serve in the role of senior advisor. And we send many thanks to all of our active members who've kept this group very lively and fun and productive over the years. And that extends to our past members and leaders, people like Susan Chakowski, and also Christine Hunter and Wendy Nielsen, who've been hugely influential to our work. Our network meets monthly, and for any interested NIHers, you can certainly join the group. We'll tell you how to join our team at the end of this talk. So our NIH group has pursued a wide variety of activities over the years to engage the external research community in advancing the science of adherence. During the thick of the COVID-19 pandemic, our group led a series of webinars on telehealth approaches to maintain care engagement and support adherence behaviors remotely. More recently, we've led a series of workshops on health behavior maintenance, which we'll be discussing shortly. And we also routinely sponsor symposia at annual scientific meetings. We were really delighted to have a full room turnout for our recent symposium at the 2024 Society for Behavioral Medicine meeting in Philadelphia, which highlighted many of the directions we'll be discussing with you today. So what are we currently working on internally? Well, our interests are wide-ranging, but our current work groups really illustrate our present foci. And one work group inside of our network is addressing social determinants of health, health equity, and adherence. And this group is led by Christopher Barnhart at the SGMRO. This group is interested to understand how adherence behaviors are shaped by important social and structural factors that frequently reproduce inequitable health outcomes. And then our second work group is working on the topic of health behavior maintenance, because we know that one of the greatest challenges is not just initiating, but also maintaining regular health behaviors over time. And one foundational activity for our work groups is portfolio analyses. Portfolio analyses examine the focus and content of current NIH research applications and awards. They also help us to see trends in research over time, as well as important gaps that we'd like to better address and fill. And I really like the evidence-based approach that this group has routinely undertaken. And we might be able to share some more about the results of some of these portfolio analyses at a future BSSRCC meeting. So I hope I've helped you understand just a little bit about the NIH Adherence Network and its current interests and operations. I'm now going to pass to my colleague Maureen Monahan-Center, who will talk a little bit more about the substance of our work.
Great. Thank you so much, Mike, and thank you to everyone for joining us today. My name is Maureen Monahan-Center. I'm a clinical psychologist and program director for diabetes behavioral science at NIDDK, and also recently stepped into the co-chair role for the Adherence Research Network. I'm going to spend just a few moments today talking about this second main point of our presentation, that adherence and health behavior maintenance are important challenges in the behavioral and social sciences. Next slide, please. So first, a brief reminder about adherence. So what is adherence? One definition, first offered by Haynes and colleagues and updated by Meir in 2023, describes adherence as the extent to which a person's behavior, taking medications, following a diet, or executing lifestyle changes, corresponds with agreed upon recommendations from a healthcare clinician or team. So adherence is really encompassing health behaviors more than just medication taking. And there's a pretty strong body of research that shows adherence to healthcare regimens is associated with improved health. However, our construct of adherence has really evolved over time, and it is a multidimensional construct influenced by a number of factors. As you can see in these related terms, it highlights some of this evolution. So moving from a one-sided view of compliance or concordance to focus more on an individual's agency and choice, and broadening the focus to self-management while accounting for a broad range of factors from the individual through the system. Next slide, please. There are multiple levels of determinants of adherence behavior. So again, it's a product of much more than just patient factors. A very recent systematic review published by Folkboard and colleagues in 2024 looked at 47 experimental treatment adherence studies and found that adherence is influenced by what they categorized as 5 broad factors, including structural, social, and economic factors such as employment, healthcare coverage, financial status, healthcare system factors, access, trust in clinicians, provision of adequate or appropriate education and follow-up, and also factors unique to the person managing their health behaviors, their condition, and their regimen. So when we consider adherence and strategies to improve or promote adherence, it's important to recognize these factors and consider interventions that are targeting multiple levels or determinants. Next slide, please. NIH has a particular interest in leveraging multi-level interventions and especially addressing health and health disparities among those who are underrepresented or minoritized. So this is an example of a research framework, but it comes from the National Institute of Minority Health and Health Disparities. And while it's not adherence specific, it certainly has relevance for some of the things that we're going to be talking about today, as it's really highlighting these multi-level spheres of influence that can be used to guide intervention development and evaluation, and consider these opportunities to really intervene upon multiple levels, including broader levels such as the healthcare system, the community, and the sociocultural environment. And so this framework is one way to really underscore the complexity of adherence and some of the challenges that we'll talk about related to both initiating and sustaining health behaviors over time. Next slide, please. So I do want to show some of the conceptualizations about this continuum of adherence. And so this framework comes from Bernard Brigens and colleagues, and it originally was focused on medication research, but I think the constructs are applicable as we think about this broader adherence research. So this framework articulates three facets of adherence. So the first is initiation. So the uptake of a health behavior or a medication regimen, or initiating that agreed upon treatment. And we know that some studies show that primary non-adherence, or never even initiating a health behavior change, is common. So one meta-analysis showed up to 17% of individuals who are prescribed a new medication do not even start that medication regimen. Once something has been initiated, there are considerations for execution of that health behavior. So how often they're either meeting that desired behavior or their consistency with executing that desired behavior. And then the third part of this framework is persistence or maintenance. And we'll spend a fair amount of time talking about that today, because we know maintenance of health behaviors, or how they're sustaining or maintaining change over time, is a significant challenge, and one in which NIH is very interested in addressing. Next slide, please. So these graphs can illustrate some of the challenges with maintaining health behaviors. This excellent slide came from Dr. Catherine Ross from the University of Florida and shows results of studies focused specifically on weight loss and weight loss interventions. So the graphs depict weight change for participants in behavioral interventions, visually showing that initial improvement in weight, but also the challenges of maintaining weight loss over time, particularly after intervention supports are removed. Next slide, please. And there are also challenges in defining maintenance. So it's not just a static in and out, yes or no, are you maintaining health behaviors? More contemporary conceptualizations really try to capture these normal and normative fluctuations that happen beyond that binary yes, no. It's not simply that you're doing the behavior or not, but there are normative challenges that behaviors wax and wane over time. And it can be difficult to really be able to define and measure maintenance. So as seen in this depiction in a paper published by Genevieve Denton, Alex Rothman, and colleagues, focused on physical activity, you can see that there's a point of uptake when something starts. Execution, there's these natural variations or changes in engagement in physical activity, and potentially a point of vulnerability or risk of disengagement. And then how do you determine that a behavior is no longer being sustained? Potentially a shift in both health behaviors and those psychological processes that support them. Next slide, please. And that has really led us to have a significant focus on a lot of the activities through the Adherence Research Network and through work that's being done through OBSSR related to health behavior maintenance. And I will now pass to my colleagues in OBSSR, Dr. Sydney O'Connor and Dr. Deborah Young-Hyman, to share more about these efforts.
Thank you, Maureen. Hello, everyone. My name is Sydney O'Connor, and I'm a health scientist administrator in OBSSR. If we could go back to that previous page just for one moment, I wanted to mention that we're excited to announce the launch of our newly created OBSSR behavior maintenance website, which you can see the link for here. And this is where you can find an overview of the effort that Deborah and myself will be presenting in the following slides, as well as resources and recordings of past events. And this website will evolve over time as more materials become available. So we do encourage you to bookmark this webpage for future reference. Next slide, please. So as described by Maureen, this effort between OBSSR and the NIH Adherence Network was motivated by the key behavioral health challenge that behavior maintenance, which can be described as sustaining health behaviors over time and across contexts, is difficult to achieve. So to advance the science and practice of behavior maintenance, we have partnered to lead a series of workshops to explore 4 overlapping and complementary facets of behavior maintenance. And those areas include conceptualization of processes and mechanisms of action underlying behavior maintenance, approaches for measurement and monitoring of behavior maintenance and relevant constructs, intervention approaches for supporting behavior maintenance across behaviors, disease contexts, populations, and settings. And finally, the promotion of behavior maintenance in clinical and community settings or real-world implementation. And again, these workshop recordings can be found on that new OBSSR behavior maintenance webpage. Next slide, please. The workshop series was developed and led by the team that you see here on this slide. The NIH leads included Maureen Monahan Center, Mike Steeret, Deborah Young-Hyman, and myself. And we were fortunate to be joined by two co-chairs external to the NIH who brought valuable and complementary perspectives and expertise to our effort. The co-chairs were Dr. Alex Rothman, who is a professor of psychology at the University of Minnesota. Alex has advanced theory-driven research across behavioral domains to improve our understanding of the underpinnings of behavior change and maintenance. We were also joined by Dr. Ann Peters, a professor of clinical medicine in the Division of Endocrinology at the Keck School of Medicine at the University of Southern California. Ann treats individuals with diabetes across the Los Angeles area and brings her on-the-ground experience and insight to the challenge of behavior maintenance. And Ann is with us today, and she'll share a word or two toward the end of our presentation. We'd also like to acknowledge the support and involvement of numerous additional members of the NIH Adherence Network who provided input and expertise throughout this process. Next slide, please. Finally, the workshop series was a success because of the subject matter experts who shared their time and insights. Many of them have joined us on this call today, so we thank you again for all of your time and effort. This slide represents the nearly 40 individuals who are involved across the series, and we're, again, really grateful for their contributions. Now I'll hand it over to my colleague, Dr. Deborah Young-Hyman, to share some of the key findings from this workshop series.
Next slide, please. Good morning, everyone. It's my privilege to present to you this morning some consensus findings from each of the workshops. To repeat first, you will find both recordings and high-level summaries on the website, which has been mentioned. Our first meeting was focused on conceptualization of behavior maintenance. A work group of 20 health behavior maintenance researchers was convened to discuss how we understand the processes of behavioral maintenance. I'm just going to give you highlights today from each of the meetings. So behavioral maintenance processes were conceptualized as dynamic and not static, looping and variable over time. You see a corkscrew on your right, which is kind of how we landed on how processes operate over time. It has multiple level interactive influences, including intra-individual, social, built, and policy environments, which all interact and affect outcomes. And finally, that it is really important to use non-stigmatizing language because behavior maintenance is often variable, as Maureen was talking about when she described the Dutton et al. Slide. Next slide, please. Workshop 2 focused on measurement. And this was an outward-facing meeting as opposed to an internal meeting. And the following were surfaced as consensus important ideas in the measurement of behavior maintenance. Standards or criteria or benchmarks, again, which you saw on that great graph by Dutton et al., of how much of a behavior is critical. For behavior maintenance are variable and or lacking across domains. So there doesn't tend to be uniformity, which makes comparisons of processes difficult. Digital technologies were called out as presenting opportunities for assessing dynamic processes and behavior patterns over time. Once again, you see I just saw a comment in the chat about what's your axis, and one of the axes is time. Measuring psychosocial processes and contextual factors alongside behaviors adds explanatory value and richness regarding how they work and how they change. And active monitoring and effective interventions are closely braided. Some say that active monitoring is in and of itself an intervention. Next slide, please. Workshop 3 regarded research interventions. The group of scientists, determined that key intervention or ingredients and approaches to maintain or sustain behavior include, but are not limited to, fostering intrinsic motivation, identity formation, and habit formation in the individual, building on values, culture, and environmental context, both within the individual's world and in their own in their larger context, providing timely nudges, cues, and prompts. Again, I referred to the graph, which showed that there are critical, or what I would call, identifying and intervening on critical moments or tipping points to help people to restart after a health behavior ends or flags. As you see, non-judgmental language. And finally, few trials, with some notable exceptions, examine sustainment of intervention effects over time. In particular, what we mean by that is when active intervention resources are withdrawn. And this is a little controversial, it's quite possible that NIH funding mechanisms can be a barrier to assessing long-term impacts. Next slide, please. In our fourth and final workshop, we focused on implementation. We did that in two ways. We had a person and clinician panel that talked about their own experiences supporting health and executing health maintenance. And then in the second session, examples of approaches in community and clinical settings were presented. In the person and clinician perspective panel, the following was surfaced. Unmet and competing needs significantly impact people's ability to manage health conditions. I call that living life. Creating consistent self-care routines and nurturing self-compassion when behavior flag is key. Permission to go off the wagon and on the wagon again. And that a trusting therapeutic alliance between clinicians and people they serve is vital for not only adoption, I refer you to Maureen's comment about primary non-adoption, and long-term practice of health behaviors. This relationship needs to be ongoing and long-term. In the session on community and clinical settings, the following were consensus ideas. Leverage available resources and community interest to help sustain community-based interventions. Again, these are non-research settings. Tailoring, implementing interventions benefits from community-based participatory approaches. Design your program with the community, whether it be the healthcare community or whether the broader community. And maintaining personnel resources over time is key and requires a retraining plan to sustain fidelity to successful health promotion programs. So when designing a community or clinical program, think ahead to personnel changes and what you need to sustain resources to sustain the program. Next slide, please. On this next slide, I present to you our patient panel for meeting 4. All of these people live with chronic diseases and manage health behaviors. On the left is James, who lives with obesity. These are quotes. I've personally dealt with obesity my entire life. I find the disease to be very challenging. I really struggle with weight and work very hard at it through behavior modification, but this is not an easy thing to deal with. Indigo lives with multiple chronic conditions. She said, some of the things that have made it difficult for me to maintain my health behaviors over time are the following: stigma, pill burden and side effects, family care responsibilities, stress around financial security, and the high and ever-rising cost of insurance. And finally, managing many physician and specialist appointments. Chip, our last patient participant, lives with cystic fibrosis. Quote, "What helps maintain my behaviors over time mostly is having a routine. I just do it. I built this routine over 20 to 30 years. My closest friends know my routines and respect them. And when we're making plans, they're very good about making space for my medical routine, my cystic fibrosis, into our plans." You can see that the themes of these personal statements reflect the themes elevated during our meetings. Next slide. So I want to briefly pivot around to next steps. Again, there's a new website, a landing page for the behavior maintenance activities. And over the next year, we will conduct a scoping review of the behavior maintenance literature through OBSSR. And we will include meeting papers and the scoping review in a special issue to be published. And at this point, I'll hand it back to Mike. Thank you.
Deborah, thank you so much. And actually, if Ann Peters is on the call, we are very fortunate to have Dr. Peters serve as one of the external co-chairs for the behavioral maintenance workshops. And Dr. Peters, I wonder if you'd be willing to come off the mute and turn on your video and just speak with us briefly about your view on these workshops.
Hi, everybody. And I loved those summaries that you heard. And working with Maureen, Sydney, and Deborah, and Alex, who's not here, has been an amazing experience. And let me just say that I see like thousands of patients because I work in well-served Beverly Hills and an under-resourced East Los Angeles. And I know all about barriers and access and everything else. But what's always puzzled me is, how do I get people to sustain change? And in clinic, I can get anyone to change for 3 to 6 months. And every bit of research looks at 3, 6 months, maybe 12 months. But that's not what I need as a clinician. And I never understood that there was an entire field of health behavior maintenance. And so I came to this really ready to learn. And I'm not sure how much I learned in a way, except I got to meet all of these experts and understand all the theories, because what I still need as a clinician is how to see a patient and understand what treatment they need to maintain that behavior and what model I could use in my brain to help them. And I think I do a lot of it without being conscious of the fact that I do it. But I have these patients who maintain their A1C at 6 for years with type 1 diabetes and others who just can't do it. And none of it's a fault. But what I really want now is to tie all of this together to make it make sense to people like me who want to be able to see an actual patient and say, what do I need to make this work for you long term? So I really am applauding the NIH for looking at this and for making this a priority, because nothing matters in terms of what we do unless it's sustained for these chronic conditions. And so I really believe that this is important to all of us. And I've just loved being part of this and loved how it's made me think. And I've loved meeting all these other experts. And I think the notion of bringing this together and then continuing it forward couldn't mean more to us clinicians who deal with people who have chronic diseases. So that's my comment.
Mm-hmm. And thank you so much. We are just so happy that we've been able to partner with you on this work. And indeed, we all share this goal, which is to advance the science, but in a way that can ultimately inform our practice to improve lives and to improve health. So thank you. Thank you very much. So I'll just conclude here on a couple of notes. We've told you today about the Adherence Research Network, about how adherence and health behavior maintenance are challenges that we want to work on. And we've also talked about our current series of activities on health behavior maintenance. And before we end our talk, we do want to mention that the road forward will involve research. And so we want to invite you, especially our external collaborators here and people who are interested in this space, to check out our current notice of special, there we go. There it is, a special notice of notice of special interest. This is a call from NIH, which is sponsored by 14 institutes, centers, and offices. And it invites research on addressing patient adherence to treatment and prevention regimens and the maintenance of health behaviors over time to promote positive health outcomes. This is a wide-ranging call for research. It includes mechanistic studies, efficacy trials, and also implementation research. We're inviting research that might focus on any number of outcomes. Those could be the initiation of health behaviors, their execution, or their maintenance over time. And we do invite multi-level interventions that are tested in the course of applications to this announcement could work at one or more levels, at the individual, family, provider, health system, or community level, or perhaps a couple of those levels, several of those levels. Inside of this announcement, which is identified as Notice OD 24-146, you will find a list of not just the general priorities for NIH with regard to adherence and behavior maintenance, but also the specific priorities of each of our participating institutes, centers, and offices. And that includes a scientific contact at each of these organizations. So if you do have research that you'd like to advance, we invite you to reach out to us and to speak with one of our scientific contacts that are listed on this notice to discuss your research ideas and your research concepts. Working together, we can truly advance the practice and the science of adherence and health behavior maintenance. So we just want to close by thanking you. We invite you to visit the new behavior maintenance website to submit adherence and behavior maintenance grant applications that cite our notice. And then there's two ways that people can get involved. If you're an NIHer and you're interested to join our group, please send an email to either myself or to Maureen, Monahan Center. And the same thing for folks who are outside of the NIH. Although we don't, the NIH Adherence Network is currently just for people who are internal to NIH. We have an email list, and we'd love to include you on our list so that we can, send you occasional messages and updates on our activities. And you can also write to myself and to Maureen on that account. Cassie, thank you for your interest. I see that in the chat there. Yes, that's great. Okay, so we'll close here and we're happy to entertain some questions. Thank you all so much. We really appreciate it.